Welcome to the virtual IKCS meeting. Excited to be here today presenting to you Into the Light, Understanding and Treating Rare Kidney Cancers. My name is Raina McKay. I'm Associate Professor at the University of California, San Diego, and I lead our GU genitourinary program here. These are my disclosures. So we'll go through the learning objectives. One is to provide an overview of rare kidney cancer, to discuss treatment options for rare kidney cancers, and to talk about clinical trials to consider for patients with rare kidney cancers. Just to go through the scope of the problem, kidney cancer is actually a very common cancer. There's about 300,000 cases worldwide, while of those, the majority, about 70%, 75% are localized. Up to about 40% of patients who have localized disease ultimately develop metastases. And of those patients who initially present with disease, about 25% of them actually present with metastatic disease up front. There's really limited effective adjuvant treatment options for patients who have localized disease without evidence of spread. There are multiple systemic treatment options that are evolving for people with advanced disease, and we'll go into that a little bit today. So kidney cancer is really not just one disease. It's been classically broken down into clear cell RCC and non-clear cell RCC. We're trying to get away from this non-clear cell RCC nomenclature and reclassify it to be called variant histology RCC. But you can see that the non-clear cell RCCs are, a grab bag of a mixed bag of just multiple different other types of tumors, such as papillary type 1 and 2, chromophobe, translocation, collecting duct, unclassified. And all of these types of RCCs are a little bit unique in the way that they developed and exactly what kind of treatments they're responsive to. When we talk about rare kidney cancers, we can't forget to talk about the hereditary kidney cancers. Typically, these cancers present at a younger age of presentation. Typically, patients have a family history. They may have bilateral tumors or multiple tumors. And more commonly, they have non-clear cell histologies. So here is a graphic that you'll see looking at the number of germline alterations or RCC associated gene mutations that are seen in non-clear cell patients. And what you can see is that about 14% of patients have germline mutations, of which, and also 1.7% have an RCC associated gene mutation that have clear cells. So, 15, 16% of patients. But when we look at the non-clear cell patients, that number is approaching 30%. So, always something to consider when we encounter one of these rare RCCs. Here is a table just denoting the most common rare syndromes and the specific type of gene alteration that results in the syndrome coming on. In addition to causing specific types of RCCs, some of these syndromes are associated with other findings. For example, hereditary leiomyomatosis renal cell carcinoma is associated with uterine fibroids and skin cancers. Birt-Hogg-Dubé is associated with pneumothoraces. Hereditary paraganglioma and pheochromocytoma syndrome is associated with these, neural tumors that can come on. So, and von Hippel-Lindau, which we'll talk about in a little bit, is associated with hemangiomas that can come on through the central nervous system, the eyes, and other parts of the body. So this is just a table kind of summarizing each of these syndromes. So sarcomatoid RCC is a little bit different, and I want to just spend a little bit of time on this. So your RCC histologies break down into your clear cell and your non-clear cell, but any type of RCC can have a subclassification of sarcomatoid. So you could have a sarcomatoid clear cell or a sarcomatoid non-clear cell. It's sort of like a subclassification of a RCC histology. And this is seen in about 20% of patients who have stage 4 renal cell carcinoma. And we'll talk about some evolving treatments for sarcomatoid RCC. As I stated, this can come on with any type of kidney cancer. So rare kidney cancers Think of it like the gumball. They have different histologies. They look different under the microscope. They have different pathogenesis. What I mean by that is each of these genes, each of these uh, cancers is driven by a unique mutation that causes that cancer to grow. And in some situations, that mutation can be targeted. They have different clinical courses. Some behave more indolent than others, and they have different responses to treatment. So even though a lot of times they're kind of pooled all together, each of the entities in this that fall under rare kidney cancers is a little bit unique. So looking at the outcomes of non-clear cell RCC. So there's been multiple studies that have been done. A lot of this work has come out of the IMDC, the International Metastatic RCC Database Consortium, which is a large pooled international database of patients with advanced kidney cancer. And we looked at outcomes of patients who have clear cell RCC compared to non-clear cell RCC. And in general, the outcomes of the non-clear cell patients tends to be inferior to those with clear cell. These patients tend to not stay on therapy as long, and their survival is lower. Now, this is a older analysis done back in 2013, but the non-clear cells have classically done worse than the clear cells. Similarly, patients who have sarcomatoid features tend to do worse compared to patients without sarcomatoid features. And multiple different studies have demonstrated this. So this is an unmet need in the field. We need to figure out more effective treatment strategies for non-clear cell patients, those with sarcomatoid RCC, and really need to develop trials that look at investigating therapies for these individuals. So let's dive in now to the treatments that we have to treat non-clear cell RCC. And first we'll go through some phase 2 studies that have been landmark studies, very instructive in the treatment of non-clear cell RCC. In the current era now with lots of combination therapies, these trials I think are a little bit outdated, but the ESPN, ASPEN, and Record 3 trial were three landmark trials that included patients with non-clear cell RCC, and you could see the different types of histologies that were allowed. And mainly these were trials that were looking at answering the question of whether a drug like Sutent, which is a VEGF inhibitor, versus a drug like everolimus, which is an mTOR inhibitor, is more effective at treating patients with non-clear cell RCC. All of these trials were done in the frontline space, meaning these were patients who had metastatic disease who had never seen any prior therapy. Patients were randomized to Sutent versus everolimus. In ESPN, they switched, and Record 3, they also switched, but this was not done in the ASPEN trial. And here is a summary of the results of these studies, which essentially have demonstrated the superiority of Sutent over everolimus. So the PFS was longer with Sutent. Seemed to be that overall survival trended towards Sutent over everolimus, and also response rates were higher with Sutent versus everolimus. And these studies helped establish Sutent as a frontline option for patients with advanced non-clear cell RCC. These are the updated guidelines from this year, and Sutent is still on this list because a lot of the trials that have recently been reported, of immunotherapy combinations, did not include clear cell patients, or did not include non-clear cell patients. They were designed just for clear cell. And you could see a preferred regimen for patients who have non-clear cell histology is actually enrollment on a clinical trial. But the most robust data, largely from those 3 trials that I showed you, really supports the role of sunitinib. Now, what about immunotherapy for patients with non-clear cell RCC or rare kidney cancers? So immunotherapy, there's 2 drugs that are, or 2 types of drugs that are used for people with advanced kidney cancer. There's PD-L1 and PD-1 inhibitors, and there's also CTLA-4 inhibitors. These are checkpoints that help, help the immune system be able to recognize the cancer. So the tumor cells kind of puts on blinders to make it so that the tumor cell can't be recognized, and these types of therapies inhibit that from happening, and therefore the immune system can recognize the cancer. And so there are some retrospective series that are instructive. There was a series that came from the Dana-Farber looking at any PD-1 and PD-L1 inhibitors for people with non-clear cell RCC, a small series, 36 patients demonstrating objective response rates of 14%. There was another series from MD Anderson, and these were all people that received nivolumab, which is a PD-1 inhibitor, included 31 patients, response rates around 16%. So what we see here is a signal of efficacy in the non-clear cell RCC patients with immunotherapy. I didn't include it on this slide, but if we were to break down all of these 36 patients and 31 patients, each of them actually have a different RCC subtype, whether it be papillary or chromophobe or unclassified. And we do see differential responses across the different RCC subtypes. For example, chromophobes tend to not really respond very well, or at least from our series, just tend to not really respond well to immunotherapy, whereas papillaries do have some responses and unclassified as well. So now, are there any prospective studies that have looked at evaluating immunotherapy in people with non-clear cell RCC? And, for this, we can go to the Keynote 427 trial, and this is the trial schema. This was a trial that enrolled patients with advanced RCC and looked at single agent pembrolizumab, which is also a PD-1 inhibitor that's demonstrated efficacy in people with advanced RCC. And there was cohort A from this trial looking at patients who've never received prior treatment, and that enrolled 110 patients. But cohort B was just for patients who had non-clear cell RCC, and this was confirmed on central pathology review. So the primary endpoint of the study was objective response. Secondary endpoints were overall survival, progression-free survival, duration of response, and additional exploratory endpoints included depth of response and overall survival. So response assessments happened initially at the 12-week mark, and then every 6 weeks until up to a year, and then every 12 weeks thereafter. And the data demonstrated that the objective response rate with frontline pembrolizumab for non-clear cell RCC patients was 26.7%. And the disease control rate, meaning people who had a complete response, partial response, or stable disease, was 43%. And this figure 3 here is what we call a swimmer's plot, and every single line here represents a patient, and you can see sort of those patients that are highlighted in dark green is the time that they were on therapy. Highlighted in light green is maybe they stopped therapy and were not taking any treatment, but we're still doing okay. The yellow triangles are the complete responses, and the orange triangles are the partial responses. And so here we see in those individuals who had a response, what happened to them. The median progression-free survival was 4.2 months. We know that progression-free survival is not the greatest endpoint for immunotherapy, and the median overall survival was 28.9 months for these patients. So now let's talk a little bit about sarcomatoid RCC. One of the biggest, things that we've learned over the last year or two from a series of trials that have tested immunotherapy combinations for patients with advanced clear cell RCC was that actually it seemed like the subset of patients who had sarcomatoid RCC that were enrolled on these studies seemed to do particularly well. Now, this is a huge stride because these patients historically had just done so poorly with the systemic therapy that we had available to treat them. And, the Keynote 426 trial looked at immunotherapy with a VEGF agent, axitinib. The Checkmate 214 looked at nivolumab plus ipilimumab. Emotion 151 looked at atezolizumab and bevacizumab. The numbers aren't very high here, and really this was a post hoc analysis, meaning they hadn't planned on doing this analysis. This was something they had done after the study had already been reported, and it didn't have central pathology review, so we couldn't confirm the pathology. But what they showed was that the objective response rates with these immunotherapy-based combination treatments was, 50 to 60% in a patient population that historically had just not responded well to therapy. And I'll draw your attention to the CR rate. This is the complete response rate, meaning everything going away on a scan. It's upwards to 18% with nivolumab plus ipilimumab. So it's very exciting to see this sort of data for patients with, sarcomatoid RCC, and certainly that is, immunotherapy combinations, and in particular, nivolumab and ipilimumab as a option for these individuals. So what is unique about sarcomatoid RCC? Why is it that these patients tend to respond better to immunotherapy? Well, for one, it looks like sarcomatoid tumors tend to have more PD-L1 and PD-1 expression compared to just tumors without sarcomatoid differentiation. There's been several studies that have demonstrated that. And we know that while we don't use PD-L1 status in RCC to, select patients for a given therapy, we know that patients who do have PD-L1 positive disease tend to do better with immunotherapy. Additionally, sarcomatoid RCCs tend to have a higher mutational burden, and that may be, immunogenic. That may be, that may stimulate the immune system in a positive way, so that the immunotherapy can work better in these individuals. All right, we're going to shift gears a little bit and talk a little bit about papillary RCC. So papillary RCC is the most common non-clear cell or variant histology RCC. It probably accounts to anywhere from 10 to 15% of all RCCs. And what is particularly unique about type 1 papillary RCC is that it tends to be associated with MET alterations and upregulation of MET. MET is a gene that is found on chromosome 7. You can see it right here. And in type 1 RCC, it tends to be mutated, tends to have either an activating mutation or gain in number. Sometimes cancers can actually gain genes, and this leads to increased cell survival, cell proliferation, differentiation, and cell migration and invasion. So it basically promotes the tumor cells to grow and survive and spread. And MET activating alterations or MET chromosomal alterations are very common in papillary type 1 papillary RCC. So I'll highlight the results of this study, the Savoie trial that was presented by Dr. Tony Shawiri at ASCO, virtual ASCO this past year. This was a trial specifically done for patients with papillary renal cell carcinoma that had MET-driven tumors. They needed to have measurable disease. They could have received prior systemic therapy in the advanced setting or be treatment naive. And patients were randomized 1-to-1 to receive savolitinib, which is a very specific MET inhibitor, versus Sutent. And Sutent doesn't really have too much activity, doesn't have activity with regards to the MET pathway. The primary endpoint was progression-free survival by independent review. And, it was approximated that 360 to 450 patients were planned to be screened in order to randomize 180 patients. And after an external data committee after external data predicted that PFS with Sutent in patients with MET-driven disease became available, the study enrollment was closed. So there was some kind of predicted data that came out about how patients were going to do on the trial, and or how they may do on the trial, and there was a decision to close the trial early. And but this is so ultimately what the trial demonstrated was that there seemed to be a trend that the savolitinib treated patients seemed to do a little bit better compared to the Sutent treated patients. Unfortunately, there wasn't a large number of individuals that were enrolled on the trial, but we highlight this to denote sort of the significance of the MET pathway in RCC. Can I pause? I seem to be missing a slide.
Yeah, absolutely.
It seems. So what is unique about sarcomatoid RCC? There have been several studies that have looked at trying to understand why sarcomatoid RCCs tend to be more responsive to immunotherapy. One is they tend to have increased PD-L1, PD-1 expression. When we look at sarcomatoid RCCs compared to clear cell RCCs that don't have sarcomatoid differentiation, we see a higher degree of PD-1, PD-L1, or PD-1 and PD-L1 co-expression. Now, we don't use PD-L1 and PD-1 expression to select patients for therapy in people with advanced RCC. However, we know that patients who have these biomarkers tend to be better responders to immunotherapy. Additionally, genomic studies have revealed that sarcomatoid RCCs tend to have a higher mutational burden or higher TMB, and that could potentially um, make it so that they respond more to immunotherapy. We're going to shift gears a little bit here and talk about the VHL syndrome. The VHL syndrome has been a syndrome that has been used to basically help us learn more about renal cell carcinomas. VHL is an inherited autosomal disease that's manifested by a variety of benign and malignant tumors. Um, and there's an association between clear cell RCC and von Hippel-Lindau syndrome. And as I said, this syndrome really became the model of investigation for renal cell carcinoma. 80% of individuals have an infected parent. 20% of individuals, it comes on sort of de novo or sort of without really a family history. And nearly all patients who have a germline mutation in the VHL gene will express the syndrome by age 65. It's a really rare syndrome. The incidence is 1 in 36,000, but about 2/3 of individuals who have this syndrome actually develop renal cell carcinoma. So what is unique about VHL is the role of HIF in RCC. And VHL is a specific protein that actually regulates HIF, which is hypoxia inducible factor. And under hypoxic conditions, HIF goes into the nucleus of the cell and turns on lots of transcription factors. Under norpoxic condition, meaning normal oxygen states where there's normal, oxygen, VHL actually degrades HIF and helps facilitate its degradation so it doesn't go into the nucleus and lead to these things that come on in the state of little or no oxygen. Well, MK6482, this pathway is upregulated in people who have clear cell RCCs, and people who have the VHL syndrome have a non-functional, VHL protein, and so HIF is constantly turned on. And that's how these patients, we believe, that's the pathogenesis for why they actually develop renal cell carcinomas. And so MK6482 is a potent selective small molecule inhibitor of HIF2 alpha. So it kind of shuts off this protein here. This data, this discovery was really led by Dr. Bill Kalin and others. And in 2019, he was actually awarded the Nobel Prize for Physiology and Medicine for the discovery of how cells sense and adapt to oxygen availability. And so this has ultimately led to a therapeutic being tested in the clinic. So I want to talk about a specific trial, this phase 2 study of MK6482 and VHL associated RCC. This study enrolled patients who had VHL disease based on a germline mutation. They needed to have measurable disease with no prior systemic therapy, good performance status. The trial enrolled 61 patients, and patients were given the MK6482, which is just an oral medication. And, the primary endpoint was looking at efficacy in the form of objective response in these patients. And secondary endpoints included duration of, the objective response in non-RCC lesions, duration of response in both RCC and non-RCC lesions, and safety. So here we see the waterfall plots of responses, and you can see that the majority of patients who were on this therapy had a decrease in the size of their target tumors. 53 out of 61 patients, or 86.9% of patients, had a decrease in size of their target lesions. And you can see here what's highlighted in yellow and orange. These are the patients with the confirmed responses. So we're seeing, great efficacy with this agent in people who have VHL syndrome. And because of this data, this summer, the FDA granted breakthrough therapy designation for this HIF2 alpha inhibitor for patients with von Hippel-Lindau syndrome. So now we'll shift gears again, talk a little bit about papillary RCCs. So of all of the RCC subsets that are out there, papillary RCC is actually the most common. It's present in about 10 to 15% of individuals. Type 1 papillary RCC is associated with chromosomal alterations that impact the MET gene, which is found on chromosome 7, and people can get MET gain. Additionally, there can be MET activating alterations within this tyrosine kinase domain of the MET gene, and it can result in a lot of pathways turning on within the tumor to basically tell a tumor cell to grow. So cell survival, cell proliferation differentiation, cell migration, and invasion. And I'll talk to you about the Savoie trial. This was presented by Dr. Tony Shaweri at the a virtual ASCO meeting this past year. This trial was designed for patients with locally advanced or metastatic papillary RCC and enrolled patients who had a MET-driven tumor, either chromosome 7 gain or MET amplification or a MET kinase domain mutation. Patients had to have measurable disease, and patients could have received prior systemic therapy and or be treatment naive. Patients were randomized 1-to-1 to savolitinib, which is a specific MET inhibitor, versus Sutent, which is a VEGF inhibitor that doesn't really have activity on MET. Patients were randomized 1-to-1. The primary endpoint was progression-free survival. The study had planned to screen about 360 to 450 patients so that it can enroll 180 patients. But after some, external data was made available about, some projected estimates for what the PFS may be in the trial, the study was actually terminated prematurely and closed early because there was some concern that the design of the study would not actually be sufficient to, meet the primary endpoint. However, the data were presented and are now in publication and in JAMA Oncology. There seemed to be a signal that the savolitinib treated patients seemed to do better over the sunitinib treated patients, and that's seen in the orange line here. Additionally, you can see the responses that were seen in the savolitinib treated patients, which are here, compared to the Sutent treated patients, which are here. So there's, some signal that savolitinib, or targeting MET, I should say, in patients who have papillary RCCs may be beneficial for outcomes. There's another study that's currently ongoing. It's called the PapMed study, being run by Dr. Monty Powell through SWOG. And this trial is taking patients who have type 1 papillary RCC with measurable disease, having received 0 to 1 lines of prior therapy, and randomizing them to receive sunitinib versus cabozantinib. Initially, the trial did include crizotinib and savolitinib. These arms were shut down at the same time that the Savoie trial was closed, and so the two arms here were Sutent and cabozantinib. And we know that cabozantinib specifically targets VEGF and additionally also targets MET. So we're excited to get the results of this trial for our patients with papillary RCC. Some other trials that are on the horizon that are worthwhile mentioning: the CONTACT-3 study is a trial enrolling patients with metastatic RCC that have clear cell RCC, sarcomatoid features, and it's also enrolling non-clear cell patients, those with papillary RCC or unclassified RCC. The trial will allow patients to have received 1 line or 2 lines of prior therapy. No prior cabozantinib, and patients are randomized 1-to-1 to the combination of atezolizumab plus cabozantinib versus cabozantinib alone. The trial is enrolling 50 patients with a primary endpoint of progression-free survival and overall survival. Additionally, on the horizon is the phase 2 CANI trial with a PI of Brad McGregor at the Dana-Farber Cancer Institute. It's enrolling non-clear cell patients who are treatment naive to the triplicate of nivolumab, ipilimumab, and cabozantinib. The trial will enroll 40 patients with a primary endpoint of objective response. So in conclusion, non-clear cell RCC remains an unmet need in the clinical care of patients with renal cell carcinoma. Consideration for clinical trials for this patient population should be considered, and systemic treatment has mirrored what we've done in clear cell RCC, though we need a more refined treatment strategy based on underlying disease biology. Thank you so much, and we hope that you and your families are safe during these unprecedented times with the COVID-19 pandemic.